So we're going to continue our discussion, and we're going to go to ovarian cancer. So ovarian cancer, right? So this is a leading cause of gynecologic cancer death in the United States. Ovarian tumors are often difficult to detect because they're usually deep in the pelvis. So that is an important point to remember in terms of your teaching. So they're difficult to detect because they're usually deep in the pelvis. So that means in a lot of cases, once again, this cancer may be advanced before the woman actually even knows that they have it. So 1 in 70 women will develop ovarian cancer in a lifetime. Family history is the most significant risk factor. Incidence increases after 40 years of age. All right. Half of women at diagnosis are older than 60 years of age. All right. So once again, deeper in the pelvis, and we're seeing it a lot more in the older women. All right. So frequency of ovarian cancer is highest in industrialized countries, and it affects women of all races and ethnic backgrounds. So I don't know what your thoughts are as to why it's higher in industrialized countries. Like, why do you think that is a reason for this type of cancer to be so high? Right. So that's something to think about. We have associated risk factors. So most cases are random, but about 5% to 10% of ovarian cancers are familial. In most cases, the mutations are in the BRCA1 gene and sometimes in the BRCA2 gene. So we've talked about BRCA1 gene and BRCA2 gene briefly in a previous PowerPoint, so you just want to refer to those notes once again. All right. Just briefly, once again, you know that these are proteins that we have, and normally they help and kill off any weird cells in our bodies. But at some point, they may end up becoming mutated, and we don't care why they become mutated. But now they're no longer functional; they're no longer taking care of us. So a family history in a first-degree relative, mother, daughter, or sister. So we're talking about risk factors here. Older age, early periods, early menarche, late menopause, obesity. Most women who develop ovarian cancer have no known risk factors, and no definitive causative factors have been determined. So there's a whole bunch of other reasons why people think that women may end up with ovarian cancer. So they've implicated fertility drugs, estrogen therapy and hormonal therapy, familial history of ovarian cancer, breast cancer, or colorectal cancer, personal history of breast cancer, and even things like talcum powder. So you can look at the notes underneath this slide to see why they're thinking that these are implicated. So just know that they are out there. So you're looking at your clinical manifestations. So keyword is nonspecific. The fact that the symptoms are nonspecific. So what are you going to see? So you're going to see things like increased abdominal girth, pelvic pressure, bloating, back pain, constipation, abdominal pain, urinary urgency, indigestion, flatulence, increased waist size, leg pain, and pelvic pain. So that pretty much feels like when any woman has a period, quite honestly, right? Maybe except for the leg pain. I mean, I don't think women get leg pain, but some of the other signs and symptoms may feel like how a woman is just having her normal periods, right? Where everything feels swollen and just uncomfortable. So anyway, keyword once again is just being non-specific. So they're vague, and women tend to ignore them. So ovarian cancer is often silent, but if you're seeing an enlargement of the abdomen from an accumulation of fluid, then you kind of want to make sure that you report that, right? So that's a common finding, apparently. Enlargement of the abdomen from an accumulation of fluid is a common sign. All women with GI symptoms without a known cause must be evaluated for potential ovarian cancer. So vague, undiagnosed, persistent GI symptoms should alert the nurse the possibility of an early ovarian malignancy. A palpable ovary, this last bullet is important as well. A palpable ovary in a woman who has gone through menopause needs to be investigated right away, because apparently the ovaries normally get really, really small and are less palpable after menopause. Enlarged ovary needs to be investigated. You're going to be doing things like pelvic examinations, even though they're not definitive in any way, but you just want to try to detect this ovarian cancer as early as you possibly can. The ovarian tumors are classified as benign if there's no proliferation or invasion, borderline if there is proliferation but no invasion, and malignant if there is invasion. Unfortunately, by the time of diagnosis, most ovarian cancers are advanced. So other tests that they can do: MRIs, transvaginal and pelvic ultrasounds, chest x-rays, and a blood test for CA-125. So remember, we've talked about cancer tumor markers already, right? So here we have what is known as CA-125, cancer antigen 125. So this is the only tumor marker that's recommended for the diagnosis and management of ovarian cancer. So even though they recommend this, there are other things that can actually show elevations in CA-125. So things like menstruation, things like a woman having fibroids, all of those things can also actually elevate your CA-125. So the main takeaway is, sure, you're going to do this CA-125, but you're most likely going to do other testing as well, just to kind of confirm this. So whether that's a biopsy, whatever, you're going to need to do following testing. Okay. And an abdominal CT scan with and without contrast may be used to rule out metastases. So you're going to be looking at your other tests as well, like I mentioned. So blood tests, looking at your CBC, your imaging studies, your biopsy as needed. You're going to be looking at cytology on ascites. So some patients actually end up with ascites, and we're very familiar with ascites already. We've talked about how that looks. So what you want to do essentially is just collect some of that ascites, and then you want to send the specimen off, and you want to see if there's any type of cancer cells in it. So they could do this with their paracentesis essentially, and collect some of the cells. Some types of germ sorry, I'm trying to say this right. So some type of cancers can cause elevations in HCG, AFP, and LDH. These are very specific types of cancers. So they're known as germ cell cancers, essentially. So they would monitor those very, very closely for any elevations in any of these levels that we've mentioned. All right, and then your treatment. So that's normal for any cancer, right? So staging, exploration, and reduction of tumor mass are basically what you're trying to do. So stage it, find out where it is, and you want to decrease it, or you want to take it out. If that means surgical removal, then that's what we're going to do, right? So if it's hysterectomy, then that's what we're going to do. Staging we've talked about already. And it's not in 5710. It's in I think it's chapter 15. I can't remember for sure, but anyway, I gave you the page for this in a different slide, so just make sure you look at your TNM system, and we went over that. So here, in terms of treatment, so this is the same as for any types of cancers, right? So and we've discussed some of these already. So things like surgery, chemotherapy, hormone therapy, targeted therapy, which we've talked about. Targeted therapy, meaning that they are making up these new drugs, and they are specifically going to attack the cancer cells, and the hope is that they're not damaging any other normal tissue at the same time, because the problem is normally when you're trying to attack your cancer cells, you're also damaging normal cells. So with targeted therapy, you are trying to attack the cancer cells specifically. You're trying to attack the programming of the cancer cells, and you're trying to basically figure out, okay, how does this cancer grow, when is it dividing, and then you're trying to attack those particular stages. And obviously radiation therapy, which we've also talked about already. So in terms of your nursing management, what are you going to do? So it's the same things we've been talking about before, right? You're going to look at the holistic patient treatment plan. A lot of it is going to be about carrying out what the orders are, but also providing emotional support, comfort measures, and giving a lot of information. You really need to be empathetic, caring. You have to be there. I mean, I think working on a cancer unit really takes a lot out of the nurse, and you really, really have to be dedicated and committed to just being there with these patients, because like I said, this is like a death sentence in some cases. So your nursing interventions after pelvic surgery to remove the tumor are similar to those after any type of abdominal surgeries. If ovarian cancer occurs in a young woman and the tumor is unilateral, it is removed. Childbearing, if desired, is encouraged in the near future. After childbirth, surgical re-exploration may be performed, and the remaining ovary may be removed as well. So you just want to go back to see if anything is amiss afterwards, right? Because the thing with cancer is that you are always getting periods of I guess exacerbation and remission, for lack of a better word. But you're happy if the patient is in remission. That's the goal, right? You don't want them to have definitive cancer signs and symptoms there. If both ovaries are removed, a bilateral oophorectomy is performed and chemotherapy follows. So just know that these are some of the treatments that can be done here. All right, so patients with advanced ovarian cancer may develop ascites and pleural effusion. So nursing care may include administering IV fluids prescribed to alleviate fluid and electrolyte imbalances, administering parenteral nutrition to provide adequate nutrition. So all of this is boring, you know this already. Comfort measures for women with ascites may include providing more frequent meals, decreasing fluid intake, administering diuretic agents, and providing rest. We've tackled this already under liver disorders. Patients with pleural effusion may experience shortness of breath, hypoxia, pleuritic chest pain, and cough, and the patient may need a thoracentesis actually to relieve some of these symptoms. So the patient with ovarian cancer has complex needs and benefits from the assistance and support of an oncology clinical nurse specialist. Absolutely. All right. So your nursing summary management. So same as any other type of cancer, but here specifically sexual identity and body image for sure. Support through testing and diagnoses, pain management, pre and post surgical care, and then nutrition guidelines as well. So no lifting, straining, maybe up to 3 months after a hysterectomy, for example. So you just want to make sure that you know exactly what the client's orders are in terms of ambulation or even having exercise after the fact. All right, so this next couple of slides are basically just talking about a hysterectomy, and once again you have the notes already. So surgical removal of the uterus to treat cancer, maybe dysfunctional uterine bleeding to treat that, maybe to treat endometriosis, non-malignant growths, persistent pain, pelvic relaxation and prolapse, and previous injury to the uterus. So any of those conditions may require that a patient has a hysterectomy. We've discussed what a total hysterectomy is, what a radical hysterectomy is, all of that, right? So under your total hysterectomy, you're going to look at the chart once again. So the way they are defining it is removal of the uterus, cervix, and ovaries, right? And then you're going to look on the chart once again for the definitions for your radical hysterectomy. And there are different approaches, which I've already mentioned from before. So obviously assessment, history, physical and pelvic examination, psychosocial and emotional responses, and how much does the patient know, because that will determine how much teaching you have to do in terms of this patient. Okay, so some of your nursing diagnoses here. So anxiety related to diagnosis of cancer, fear of pain, possible perception of loss of femininity or childbearing potential, disturbed body image related to altered fertility and fears about sexuality and relationships with partner and family, acute pain related to surgery and other adjuvant therapy, deficient knowledge of the perioperative aspects of hysterectomy and postoperative self-care. So obviously some of these nursing diagnoses, because this is one PowerPoint with cervical and ovarian cancer, right? So some of these are basically relating to both types of cancer. Collaborative problems, so hemorrhaging, DVT, bladder dysfunction, infection. So goals, relieving of anxiety, acceptance of loss of the uterus, absence of pain or discomfort, increased knowledge of self-care requirements, absence of complications, right? Anxiety, we've done a lot of these already. Body image, we've addressed a lot of these already. Interventions, monitoring for complications, we've also done a lot of these in previous lectures as well. Radiation, we've talked about previously as well, and we've discussed the different types of radiation, external versus internal types. And then there's also something known as an intraoperative radiation therapy. So here all they're doing is they're applying radiation to the area during surgery. So they go in, they apply radiation, most likely just to get to the cancer directly. And then, every treatment is pretty much the same after that, right? So here, placing the ovoid and a tandem in there. This is for internal radiation therapy, so this is just an example. And then your nursing considerations related to intracavity radiation therapy. So remember, we talked about radiation therapy already, so this is specific for intracavity radiation therapy. So we've talked about some of these things already. So patient isolated in the room until application treatment is done, making sure they have a Foley catheter. So you don't want them to get up and move around, right? To get up to pee or anything like that, because they might dislodge the radiation that's been implanted. So we don't want that. So absolute bed rest, positioning restrictions, low residue diet, because you don't want them, pooping a lot either, right? Because if they have a high residue diet, what does that mean? They're going to be pooping a lot, so a lot of movement. We don't want that. So they can adjust the diet accordingly. So hygiene, of course, monitoring of the patient, side effects of therapy, emotional support of the patient, and address potential for isolation problems. Some patients are going to feel isolated, so you're making sure that you're discussing all of that with them. Follow specific precautions related to time, distance, and use of shielding. So I've talked about this in a previous slide already. Methods to monitor the staph exposure, so they can have the film bandages or the dosimeters that they put on. Most places the age limit is 18 years and younger. They are not allowed to go see these patients. So no pregnant caregivers and no pregnant visitors or visitors younger than age 18 years is usually the norm, okay, for anybody that's getting radiation therapy like this. Education for family and others in contact with the patient. We've talked about some of this already. Monitor that the device is not dislodged. If it is dislodged, do not touch the radioactive object. So that's huge. And you have to notify the radiation safety. You have to follow the guidelines on the unit. So I do know that from just what my friends told me with their experiences with this dislodgement of the device, they do have like this long prong that they may have in the room, and you use that long device. Basically, if this thing dislodges, you use that prong, you pick it up with that, and there's usually like a special container that you have to put it in, and then you have to call radiation safety basically, and they're the ones that are responsible for basically getting rid of the dislodged radioactive object, right? So you don't touch it, keyword, you're not touching it, and you have to use whatever the long devices that they have for you to pick it up and then put it into the bin that they have, and you call somebody to take care of the rest of it.